Hi, I'm Jennifer Allen, reporting for RSNA News. I'm talking with Dr. Stephanie Spottswood, pediatric radiologist and Emerita Professor of Radiology at Vanderbilt University in Nashville. We're talking about the healthcare inequities and disparities in pediatric radiology. Thank you, Dr. Spottswood, for joining me today.
Thank you so much for having me speak on this topic that I'm very passionate about.
So my first question for you is, how do you characterize healthcare inequities in our society in general?
Well, in general, we would characterize or perhaps define health inequities as differences in health conditions or the distribution of health resources between different population groups. And these are influenced by social, economic, and environmental disadvantage. And we find that those who are disadvantaged have greater obstacles to health based on their racial or ethnic group, perhaps, or maybe education or income or geographic location or other reasons. Now, this should be contrasted with health equity, which is the opportunity for everyone to attain their highest health potential. And health equity is a paradigm where everyone has the opportunity to be as healthy as possible, no matter what their background is. And it means giving special attention to the needs of those who are at greatest risk of poor health based on social conditions. And I just want to add that this topic is really important because we've made such a tremendous amount of progress in healthcare and improving health outcomes over the past several decades, yet we still see significant disparities in health outcomes among different populations. I mean, just look at the well-described racial disparities in outcomes of patients with COVID-19, where Blacks and Hispanics are disproportionately affected and have worse outcomes. And then all of this has, of course, tremendous social and economic costs, both to the adversely affected individual and to society as a whole.
Are healthcare disparities a serious problem in our pediatric population?
Well, children who are from the same backgrounds or communities as adults who experience health disparities would be expected to experience similar health inequities as adults. There are several studies in the literature now that describe racial differences in the care of pediatric patients. For example, Black children are less likely than white children with the same presenting symptoms to receive pain medication by emergency department physicians. And they're also less likely to be admitted to the hospital, and they're less likely to be prescribed antibiotics by their primary care physicians. And since this discussion is really about disparities in pediatric radiology, we should probably consider some of the studies that have illustrated disparities in pediatric imaging. We know that non-Hispanic Black children, in comparison to non-Hispanic white children, are less likely to receive, diagnostic imaging as a whole during ED visits, and they're less likely to undergo more advanced imaging, such as cross-sectional CT scans. And these disparities persist when studies control for health insurance status and household income and type of diagnosis. So socioeconomic status is not the whole answer here. But let me just give you an example. A non-Hispanic Black child presenting with abdominal pain due to suspected appendicitis may not be as readily referred for advanced imaging to make a definitive diagnosis. And this can result in delayed diagnosis and poor outcomes. And it's just important to recognize this because these practices are really important quality of care issues, and they can also affect a child's quality of life.
So what are some of the root causes of these disparities?
Well, the causes are likely multifactorial, and this would require a discussion on the social determinants of health. These determinants include things like access to good schools, to good education, to safe housing, to availability of nutritious and healthy foods. access to good jobs with fair pay, jobs with health insurance, transportation and public safety, as well as access to high quality healthcare. And these determinants also include issues related to bias, discrimination, and racism. Now, if you look at that scenario I described previously about Black versus white children being referred for diagnostic imaging, imagine a scenario where a primary care physician in the community refers a white child for advanced imaging for abdominal pain, while you might have a scenario where a Black child does not have a real medical home and a primary care provider to drive such imaging. But there's another really, really big factor. The Institute of Medicine several years ago reviewed about 100 studies, more than 100 studies showing health disparities for ethnic and minority populations. And these studies were actually controlled for income and insurance status and education, and they found many disparities in healthcare delivery and health outcomes are due to stereotyping and unconscious biases that contributed to unequal treatment of racial and ethnic minorities.
Can you explain a little bit more about what unconscious bias is?
Oh, sure. Unconscious bias refers to a mechanism in the brain that operates on associations. It's an automatic response. It allows us to quickly interpret and respond to the world around us. And this is a completely normal function, and it's designed for protection. These biases are actually triggered when we quickly assess people in situations, sometimes when we're in a hurry or just routinely, and then we draw upon assumptions that we have about individuals and groups to make decisions about them. But the unfortunate thing about unconscious biases with respect to making assumptions about individuals and groups is that they can have unintended and sometimes harmful consequences when we rely on these assumptions or stereotypes to make decisions about them. We may make connections between people and assign them to either negative or positive or assign to them negative or positive attributes based on what we perceive as their social identity. And this might impart more value to some people than others. A health equity specialist at Harvard once said that if you hold a negative stereotype against a group in your subconscious mind, and then you meet someone from that group, you will discriminate against that person and treat that person differently. And it's important for everyone who's listening to understand that these biases occur unknowingly. I mean, even by the most well-intentioned, and they're based on influences of our past experiences and associations and perhaps what we see in the media. And it's also important to know that while most physicians are not explicitly racist or prejudiced, studies show that physicians also manifest the same implicit biases and stereotypes found in the general public. Emergency department physicians don't wake up in the morning and decide, I'm going to go and discriminate against a Black child this morning. That just doesn't happen with this type of phenomenon. Unconscious bias can lead to an actual discordance between a physician's intent and egalitarian beliefs to provide good care and the kind of care they unintentionally actually provide as a result of their unconscious biases.
So how can radiology be part of the solution?
So that's a bit of a challenging question. And I would look at it through the lens of three different areas, because a lot of times radiologists are not as patient facing as some other medical specialties. But I would say that the first thing we need to do is recognize our biases and try to figure out a way to mitigate them so that they don't have unintentional consequences. I think it's important for trainees as well as attending physicians to work toward developing an increased awareness of their blind spots and recognize that providing equitable and optimal care requires a lifelong reflection and attention to these biases. If you take a course on unconscious bias, your biases are not going to disappear. It's really an intentional lifelong process. And then physicians should kind of put into context the impact of their own cultural background on their ability to provide optimal patient care. And another thing that we can do is we can take the implicit association test that's available at implicit.harvard.edu. And this test looks at the relative strength of associations between pairs of concepts. And if you take a test, it may uncover your hidden biases outside of your conscious awareness and control. And again, I should point out that much of the patient care rendered by pediatric radiologists is not patient-facing, and we frequently do not see the patients whose diagnostic studies we're interpreting. However, for those studies or opportunities where we are face-to-face with a pediatric patient and their family, or their parents, we must not let our biases influence our assumptions about the patients and their families. For example, if you're performing an exam like an ultrasound or an upper GI, we should be very wary of any preconceived notions about the family's ability to pay, for example, if they need a recommended follow-up exam. And we also should not assume their preferences in terms of perhaps advanced imaging. We should make every effort to communicate clearly and transparently and without bias to the family and to the referring clinician about our diagnostic findings and our recommendations for follow-up care. Also, interpretive services for non-English speaking patients should be used generously if we're going to ensure effective follow-up of our recommendations. And this helps eliminate bias as well. So I got a little long-winded there, but the first thing I said was to recognize our biases. The second thing that radiologists can do is try to improve workforce diversity. Radiologists are not, well, let me put it this way. A very small proportion of the radiology workforce is underrepresented minority, primarily Black or Hispanic. That proportion, I think, is something like 6.5% of all radiologists. And there are studies who show in adults that racial and ethnic concordance between the physician and the patient is associated with improved health outcomes. And these studies are kind of limited in pediatric healthcare, but the assumption is that greater diversity in the radiology workforce would disrupt some of the stereotypes associated with unconscious bias, leading perhaps to a higher quality of care for people of color, for vulnerable populations. We know that radiologists in particular can support programs like the ACR Peer Scholar Program, and PEER is P-I-E-R, it stands for Pipeline Initiative for the Enrichment of Radiology. And this is a summer internship that gives medical students who are underrepresented in medicine, as well as women, an opportunity to explore this specialty of radiology and engage in research. And then I said three things. The third thing would be to address structural racism in our institutions. And I know we've heard a lot about that recently in the media. Institutions can strive to build stronger relationships with communities of color, with vulnerable patient populations. Institutions can seek ways to help patients who are disadvantaged because of a lack of access to good jobs that offer health insurance, and help them get the care that they need. We can also help vulnerable populations and marginalized patients from communities of color understand why imaging is being done. We can help these patients in particular to learn to trust their radiologists who are providing recommendations based on the results of the imaging exams. And radiologists can do things like offer information before exams so that there will be reasonable expectations about why the exam's being done and what kind of results may occur. And then the results afterwards should be explained very clearly in the language and terminology that the patients will understand. And, you know, I think the care should also include, as much as possible, an understanding of the different cultural needs of the community when it comes to imaging.
This was a lot of great information. Thank you so much for your time today, Dr. Spottswood.
It's been my pleasure. Thank you for having me.
For more radiology news, visit rsna.org/news.